Do you want it like this, or do you want it?
No, it doesn't. It absolutely does not matter to me. I can do either way.
Got it. Okay. Thanks, Jeff.
Thank you, sir.
Let me know if you need me.
I will.
You need a mic or anything?
No, a lavalier mic or anything? Or no? We just have the hands.
Yeah, but we just have the handheld.
I'm good.
Okay.
Good. Thank you.
No problem.
All right. Thank you for your patience. Mr. Newsom, thank you. Let's give him a round of applause, right? Someone forgot their cell phone up there? Anybody? No? Where'd you find it? I remember. P2s? They're 105? Oh, they're down to 105. Thanks, Sean.
No problem.
All right. So a couple of housekeeping items. All right. First of all, if you got my email today, I just did a little quick cleanup on the older diuretic lecture that I had up there. I had a little bit of time. I was just kind of going through it and simplifying it a little bit so we didn't get dug into the weeds too badly. So we're going to cover that today. I've also uploaded some self-assessment or practice questions for you, okay, on Canvas, and I've also uploaded them with the answers, okay? So you can check yourself later on. Again, remember, what you want to be doing here is if you've got practice questions, whether I've given them to you or you're using an AI platform to generate them, okay? Make sure you attempt to answer the question yourself first, right? And then check the answer. Even if you can't remember what the answer is or you get it wrong, it still is beneficial to memory formation. So it's kind of like you get the best of both worlds. Even if you miss something, the act of just trying to remember it actually helps to enhance memory formation when you see the right answer. So don't be afraid to miss something or not be able to remember it. You're still getting a ton of benefit from it. That's the research shows, okay? Secondly, if you're using a platform like ChatGPT to generate practice questions for you, okay? Did I give you guys my adaptive testing prompt for ChatGPT? When did I do that?
Yes.
Last year. If you have that file, does it say version 3 on it? If it doesn't, let me know, and I would be happy to send my latest and greatest version on there, okay?
You just resend it, because
I'll just send it. I'm just going to resend that, okay? I'll resend that out to you guys. But the benefit of something like that is in the instructions, okay, it tells the AI to utilize the learning objectives as a framework for developing the practice questions that you're getting. That's important. Because if you just ask it to test you on stuff from your lecture, what it may do is test you on things that you might not need to know or is not necessarily super important. This is going to get really critical, especially when you get into the more lengthy lectures with lots of slides and information, okay? I tend to think most of the stuff I use is pretty focused, right? But again, and always verify and check your answers with your notes and what's in your notes. The other thing that my prompt does is it specifically directs the AI to test you right from the PowerPoint slide. So it's not going out on the net and grabbing stuff that's unrelated, okay? It's going right from the PowerPoint slides. And then it'll generate that performance report for you at the end. And it'll tell you what your level of proficiency is for each of the learning objectives. Man, if I had this when I was a student, I can't even, it's like a game changer, right? Why would you sit there and stare at your notes for hours and hours when you can, have a conversation with this platform and test yourself and dig deeper? Let's say you miss a question, you don't know what the answer is, you don't understand the answer. Can you give me a more detailed explanation? Can you explain it to me at a 6th grade level? Can you give me a memory mnemonic that will help me to remember? It will do all of that for you, okay? Versus sitting there and rereading your notes over and over again, which is not going to cut it, okay? All right, that's the two things. Now, one of the things that I wanted to talk about from yesterday that I forgot to mention before we get into the diuretics has to do with the calcium channel blockers, okay? There is an important side effect that occurs with one of the major classes of calcium channel blockers that we talked about yesterday. Remember, you remember, don't shout it out now. You just sit for 5 seconds and think, what are the 2 classes of calcium channel blockers? Just sit for a second and think, what are they? Okay? 2 classes. You remember what they are? Who gives me one? Anybody want to give me one? Dihydropyridines, right? And the non-dihydropyridines, right? Okay? Now, dihydropyridines lower mean arterial pressure. How? What do? What's their major mechanism of action? They reduce what? TPR. And the component of TPR is SVR that they look, right? What do your non-dihydropyridines do?
Lowers everything.
It kind of lowers everything, right? It lowers systemic vascular resistance. They have these cardiac effects, right? Diltiazem and verapamil. They slow heart rate. They reduce force of contraction. All right, now let's talk about the side effect here. One, the dihydropyridine calcium channel blockers cause a unique side effect called reflex tachycardia. Okay, reflex means that it's the tachycardia, which means high heart rate, is occurring as a result of something. Reflex meaning, when you have a reflex action, like, you get scared, you jump like that, and you put your hand on a hot surface and you pull it back. That's a reflex action, right? And tachycardia means high heart rate, okay? So this not only occurs with your dihydropyridine, nifedipine, amlodipine, nicardipine, isradipine, right? But it also occurs with other drugs that are really good vasodilators, things that cause your arteries to relax quickly and significantly, okay? Because when that happens, right, you give a drug like that and very quickly it gets on board and it starts to relax your arteries throughout your systemic circulation, right? SVR drops quickly and significantly, and your blood pressure drops quickly and significantly. Now, do you remember from biomed, I'm sure Dr. Joshi talked about this, about structures called baroreceptors, right?
Yes.
Okay, for those of you that are a little fuzzy on that, baroreceptors are specialized nerve endings, okay, that are embedded in arteries throughout the body. And their job is to monitor blood pressure on a minute-to-minute basis, right? So let's say you're a patient and you're taking a short-acting dihydropyridine calcium channel blocker, and all of a sudden your blood pressure falls really quickly because your arteries are relaxing and dilating. Your baroreceptors will detect that, and they will automatically activate the sympathetic nervous system, okay? And when that happens, the sympathetic nervous system is going to increase heart rate and stroke volume, okay? And that's where you get your reflex tachycardia. The greater and faster the drop in blood pressure, the more reflex tachycardia that you get, okay? And some drugs are really noted for doing that, okay? Some drugs will do it, but not to a too bad extent, okay? And the dihydropyridines do it for 2 reasons. Number 1, because they relax arteries very well, right? Okay, as compared to like diltiazem and verapamil. The other thing is, well, let me ask you a question. Why doesn't diltiazem or verapamil cause reflex tachycardia? Let's pretend that for a second that they were really good vasodilators too. They still wouldn't. Why? Because they suppress heart rate, right? Okay, so even if you get reflex activation of the sympathetic nervous system, diltiazem and verapamil is still blocking the SA node in the heart and preventing that heart rate from going up. Okay? So, bottom line, if you're still confused about baroreceptors, if you're not really sure about what I just said about verapamil and diltiazem, the baseline thing that you need to know, okay, is that certain types of dihydropyridine or DHP calcium channel blockers can cause reflex tachycardia, okay? Your non-dihydropyridines don't do that, verapamil and diltiazem. okay? And again, if you want to go a little step deeper, which you don't have to, but they don't do it because they're not super good vasodilating agents, first of all. Secondly, as part of their mechanism of action, they lower heart rate and cardiac contractility just through their mechanism of action, right? So they wouldn't cause an increase in heart rate, okay? Take them out.
So just to get this straight.
So let's get it all straight.
Yeah. So this is the mineral receptors activate
SNS, yeah. Sympathetic nervous system.
so it will not return increase the heart rate.
Yeah. It will attempt to bring blood pressure back up by increasing the heart rate, right? Stroke volume, okay? And even it will try to constrict blood vessels, but because the drug is on board, it's not going to be able to do that.
That would return increase stroke volume.
Yeah, and heart rate. That's why you get reflex tachycardia, okay? If you've ever felt, like if you've ever gone hypotensive, if you stood up really, really quickly and you feel like you're going to pass out, you've got orthostasis. Sometimes, in some people, you can actually feel the increase in heart rate that's going on because your sympathetic nervous system is trying very quickly to get that blood pressure back up so you don't pass out and fall over. Okay? That's reflex activation of the sympathetic nervous system, and it can cause high heart rate. Okay? You got it? You guys got that? That's one of the practice questions, so see if you can get it right, okay? If you're confused about that, well, let me know. Come by my office. I'll draw it out. We'll get it down quickly, all right? All righty. Diuretics, last class. This is your last class of first-line agents, okay? Remember, there are a lot of other antihypertensive drugs that we use in different situations. There's beta blockers, okay? Which are probably the most used second-line agents. If Dr. Naeem were here, she would probably agree with me on that. But maybe not. There's potassium-sparing diuretics like spironolactone we can use. We'll talk about that today. There are alpha blockers. There are vasodilating agents like minoxidil, okay? So there's a lot of different drugs that we're not going to get a chance to cover. But I wanted you to at least know how these top 3 drugs work. So let's take a look at some learning objectives, okay? Unfortunately, for those of you out there that are not terribly excited about medicinal chemistry, there's going to be some med chem today, okay? A little bit, all right? I'll tell you exactly what you need to know. And by the way, will you have med chem questions on my exam? Yeah, okay? But I will try to give you all the practice that you need to do them, okay? So the med chem practice questions that you've got on there, if you can do those and you feel comfortable with them, you're probably going to be okay, all right? I don't want you to miss questions because of that, but this is going to be much more pharmacology, physiology heavy, okay? All right, so we're going to discuss the chemical structures of agents of the thiazide and potassium-sparing diuretic category. So we're going to talk about 2 specific groups of diuretics today. We're going to talk about their specific structural features and how that relates to their mechanism of action. Just like we did with, for example, the dihydropyridine calcium channel blockers. And then we're going to talk about the pharmacological mechanism of action of our diuretics, okay? So again, with these, you have to know how they work on different levels, okay? So for example, each one of our diuretic classes, okay, work in different parts of the nephron. So you got to know what part of the nephron thiazide diuretics work in, or your potassium-sparing diuretics, or your loop diuretics, okay, which we won't talk about today, but we'll talk about in a week or 2, all right? You also need to know what protein or molecular target do they bind to and inhibit, okay? And then you need to understand how that changes the function of the nephron, okay, that ultimately leads to a loss of sodium and then subsequently water, okay? Because that's what diuretics do, okay? They stimulate sodium loss from the body. They're natriuretics. And as a result of that, water leaves the body, okay? I know it's not a perfect adage, but you guys have all heard it, where sodium goes, water follows, right? I mean, there's a lot of physiologists and biochemists out there that are cringing because I just said that, but frankly, it got me through school. If it got me through school, it'll get you through school, okay? All right, so again, we're going to go through all of this stuff today, all right? Now, starting off, let's just do a broad overview. There's a lot of different classes of diuretics, okay? You guys probably talked about loop diuretics when you talked about, in the GI module, you guys talked about liver disease, right? Okay. So again, you possibly know some of this already. We're not going to talk about loops today per se, but they're important in heart failure treatment and not necessarily hypertension treatment, okay? So 5 different classes of diuretics. We've got osmotic diuretics, okay? We've got loop diuretics, which again you talked about when you talked about, liver diseases, right, the GI module. The 2 we're going to talk about today are in bold and italicized print up here, thiazide and thiazide-like diuretics. I want you to star this one because this is a first-line agent, or these are first-line agents to treat hypertension. 2 major examples, okay? Hydrochlorothiazide and chlorothalidone, which I'm sure if you work in a community pharmacy, you've dispensed a gazillion times, okay? And if you haven't, talk to somebody who does, okay? All right? Potassium-sparing diuretics. We're going to talk about these. There's one or 2 examples in this general pharmacological class that we can use to treat hypertension as more of a second-line agent. We can use it also in heart failure. Those are our mineral corticoid drugs. Has anybody here heard of spironolactone?
Yes.
Right? Or clarinone? That's what we're talking about there, okay? So we will talk about that, but they're not mainline drugs to treat hypertension. Then we have other drugs, other potassium-sparing diuretics like amiloride and triamterene. Okay, you'll see is they're formulated with other types of diuretic drugs to help prevent potassium loss from the body. So you'll see them in a lot of combination agents. They're never. I don't want to say never because never and always are a bad thing to say, but I'd say extremely rarely would they ever be used by themselves. Okay. All right, and then we have carbonic anhydrase inhibitors, which I believe still used for glaucoma. Okay, right? All right, which I don't teach, but I'm pretty sure that. Okay, so general mechanism of action. So if we could just take a broad paintbrush and paint a broad picture of how our diuretics work. Okay, as I mentioned before, they're all natriuretics. Okay, so all of your diuretic agents in one form or another that we're going to talk about promote water loss from the body, okay, by stimulating or causing sodium loss. Because remember, where sodium goes, water follows. So if your body is getting rid of sodium through the urinary system, guess what else is coming out with it? Water, okay? So the purpose of diuretic intervention, hopefully, is to reduce blood volume, okay, by reducing water, okay, and hopefully, okay, without disturbing electrolyte balance. Hopefully is a big word there, okay, because guess what? All of these drugs, right, they can cause electrolyte imbalances, and you need to know that, okay? Not only do you need to know how they work, but you need to know what electrolytes do they also impact, because it's not just sodium, okay? We're going to look at potassium, chloride, magnesium, calcium, okay, as a few. And, you've got to be aware of this, because in a lot of cases with these, some of the monitoring parameters is you got to be looking at your electrolytes, your patient's electrolytes, to make sure that they're still in normal levels, right? Okay? And using different strategies to combat that. Right? So mechanism of action is important, and effects on electrolytes are important. Everybody got that? We're good? Okay. All right, now, let's talk a little bit about extracellular fluid regulation. That is also, okay, something that diuretics will do. So in the case of hypertension, your diuretics, through at least one mechanism, lower blood pressure by lowering blood volume, and we'll talk about that. But diuretics can also be used to lower excess extracellular fluid. That's any fluid or water outside the cells, okay? So again, if you have a patient, for example, with heart failure, okay, and they have an acute exacerbation or they're not being monitored well, okay? How can excess water in their body show up? How would you know that they've got like too much water in their body? Edema, where?
The legs.
In the legs, right? In the ankles and the lower legs, right? They get edema there. What else?
Arms.
What's that?
The belly.
Yeah, they can get maybe a distended abdomen a little bit, right? What else? Hands, right? You get swelling there. What besides swelling? What else would you see? What's another sign of heart failure?
Trouble breathing.
Trouble breathing, right? They're like short of breath. They can't, right? Because maybe their lungs are full of fluid, right? How do you think we would deal with that? What drugs could we use? Diuretics, right? Right? If you've got a lot of ascites fluid, right? If you've got liver fluid, what do you use? Loop diuretics, right? They're really powerful. But for hypertension, okay, we're not really too worried about this, unless the patient has other issues like kidney problems, heart failure, those sorts of things. But like if someone like me with hypertension, okay, if I'm taking hydrochlorothiazide, it's probably helping me just lower my blood pressure. I'm not worried about excess fluid or anything like that, okay? But again, CHF or just heart failure, cirrhosis of the liver, renal failure, we use diuretics here. So you're going to talk about diuretics again in the next module, all right? All right. Now, compensatory mechanisms. Your body will actually fight the effects of some of your diuretic agents, okay? So, you start a diuretic on board, and after some time your patient's on that drug, your body will begin to adapt and try to fight the effects of that drug. And this is a phenomenon called diuretic braking, okay? Diuretic braking. We see it with loop diuretics. We also see it with thiazide diuretics. Okay? And basically what happens is it's a compensatory process, all right? And the body becomes resistant to the effects of the diuretics. And it does this by utilizing biochemical and physiologic systems that will help your body to hold on to what? Water and, what's the ion? Sodium. Very good, okay? So again, one of the big things is increased activation of the sympathetic nervous system, okay? So again, as your patients are on, especially strong diuretics or loop diuretics, you'll get a reflex activation of the sympathetic nervous system, which will help to activate the RAS system, right? And what's the hormone produced by the RAS system that causes your body to hold on to sodium and water? Aldosterone. And what does it cause your body to secrete? Potassium. Very good. Don't forget that, okay? All right. And then you also can get the release of antidiuretic hormone, which will lead to help your kidneys to hold on to water by stimulating the production of proteins called aquaporins, all right, in certain parts of the nephrons, okay? But again, the thing here is if you don't remember those details, which you should, but at least at this point, all I want you to understand are that certain diuretics, like loop diuretics and thiazide diuretics, your body will try to work against their mechanism of action. They'll try to compensate for that, okay? And again, if that happens, the diuretic will become less effective, but there are strategies to deal with that, okay? You can still use them. We just have to maybe use them with a different type of drug, a second drug, or use them in a specific way, okay? And Dr. Naeem will be talking about that, I'm sure. I don't know for sure, but I'm guessing she is, okay? Questions about diuretic braking? We're good? All right. Now, in terms of the primary site of action, and I've already said this, but I'm going to reiterate it because it's important. These drugs all work in the kidneys, specifically on nephrons. Now, you'll remember from Applied Biomedical Sciences workshop that the nephron is the functional unit of the kidney, right? Sort of like the neurons in your brain, right? There's billions of neurons in your brain. Well, there's billions of nephrons in your kidneys, right? Each individual nephron is responsible for filtering blood, right? Helping to regulate blood volume and electrolyte levels. So those little nephrons are super important. Well, your drugs, your diuretic drugs, will work on these nephron structures and alter the way that they handle sodium and water. Okay? Now, what electrolytes are impacted by diuretics in general? A lot of them. Sodium, potassium chloride, bicarbonate, magnesium, calcium, uric acid, and hydrogen ions. Okay? It's a lot of lists. When we go through each of the diuretic agents that we're going to talk about, I will tell you specifically the electrolytes the major electrolytes that are being impacted. Guess what? You got to know. Okay? You have to know those. All right? And the impact on the electrolytes really depends on the diuretic you're using, because you're going to find out that loop diuretics, all right, impact electrolytes differently than thiazide diuretics do, or potassium-sparing diuretics do. Okay? Efficacy. Remember that fancy pharmacological term I talked about in Module 1, right? Efficacy refers to how powerful a drug is, right? For example, morphine, right, is a more efficacious pain-relieving drug than Advil, right? Okay? So diuretics are the same way. Their efficacies are different. Loop diuretics have the greatest efficacy. They're the most powerful, okay? Followed by thiazide diuretics, okay? And some of your potassium-sparing diuretics. But their efficacy is dependent on where they work in the nephron and how important that part of the nephron is for sodium reabsorption. Okay? Got that? And I'll show you that in a little bit. Okay? Also, what's really neat here, and we can use this concept to help us with diuretic breaking, is that you can use two different diuretics together that have different mechanisms of action and work in different parts of the nephron. Okay? And we can use that, okay, to accomplish a couple of things. To help reverse diuretic breaking, to help us prevent potassium loss that we see with hydrochlorothiazide and loop diuretics, okay, by using a second diuretic agent that prevents that. So again, you're going to see combination uses of diuretics. Again, when we're talking about hypertension therapy, not necessarily. Okay, it's going to be pretty much straight up hydrochlorothiazide or chlorthalidone. Dr. Naeem's going to talk about that, right? But again, in special circumstances, we can add a second diuretic, right, to help to reverse diuretic breaking or to help prevent potassium loss, especially when loop diuretics or hydrochlorothiazide is being used. Any questions about that? We're good? All right. Ta-da! This is your nephron. Okay, you remember this from biomed. Sort of, right? Okay? So as we go through this, you're going to have to know, all right, the different segments of the nephron. Okay? And you already had to learn that. It's just going to be a little bit of a refresher. For example, at the beginning of the nephron, we talked yesterday about the Bowman's capsule and glomerulus, right? And with the afferent and efferent arterioles. This is where blood filtration takes place. Blood comes in through the afferent arteriole, right, and leaves the glomerulus from the efferent arteriole. And water, electrolytes, and small molecules are filtered through the glomerulus and into the first segment of the nephron called the proximal convoluted tubule, right, or PCT, right? Now, what I want to tell you is, okay, that 65 to 70% of sodium, okay, and almost 100% of glucose that's filtered here in the glomerulus is reabsorbed in the proximal convoluted tubule. Super, super important. Your kidneys are designed to hold on to sodium. They are, okay? I don't know if they were originally, but they evolved that way or whatever, okay? You know why? Why do you think your kidneys are designed to hold on to salt? Do we need to hold on to salt today? Do we get enough salt in our diet? Yeah, everybody shake their head. Yeah, we get way more salt than we actually need in our diet. But if you go back 500 years in time, was salt widely available over the planet?
No.
No. In fact, it was very much coveted, and it was traded, and people got wealthy on salt because people didn't have access to it. All right, it wasn't in their diet. Okay, it was a special treat if you had some. It was expensive. Okay, and that was for the greatest part of human history. It's only been recently, within the last 150, maybe 200 years, where we've had regular access to salt in our diets, and our kidneys aren't necessarily built to handle that real well. Okay, but at any rate, like I said, 65 to 70% of the sodium that's filtered here in the glomerulus is reabsorbed right here in the proximal convoluted tubule. 100% of glucose is, until the filtered glucose gets to a certain level and gets too high and overwhelms this reabsorption mechanism, and then it starts to spill into the blood, into the urine. Okay? This happens in disease states like diabetes, right? We're going to talk about that towards the end of October. I'll be back. Okay? I'll be back. All right. Then we've got the as the proximal tubule straightens out here, we go into the next big section here, which is the loop of Henle, right? Okay. Guess what type of diuretic agents work in the loop of Henle? Loop diuretics. Very good, right? Okay, good. You guys got it. And in fact, you see this little black dot right here? This is the sodium potassium 2-chloride symporter protein. This is your target for your loop diuretics. Okay? Did Dr. Hong teach you that? Did he teach you guys loop diuretics and GI? He probably did. He talked about it. Yes. Okay. All right, good. Now, at the end of the nephron, we've got the distal convoluted tubule, right? So any sodium that hasn't been, pulled back into the blood or reabsorbed into the blood, it can be reabsorbed here. Okay? You see this black dot right here? If my laser pointer's not going all over the place like that, you see it right there? Number 4. Okay? That is the protein target for thiazide diuretics. That is the sodium chloride symporter protein. Okay? And then we've got our collecting tubule and collecting duct. Okay? Last segment of the nephron. This is the last part of the nephron where sodium can be reabsorbed. So any sodium that's left, this is the last chance the nephron has to capture it there. Sodium reabsorption, and this is super important, you learned this already. Sodium reabsorption in the collecting duct or tubules is regulated by the hormone aldosterone. Okay? This is where aldosterone works. Remember, aldosterone causes the kidneys to hold on to sodium and get rid of what? Everybody all together now. Secretes what? Potassium, right. Hold on to sodium, get rid of potassium. Okay? You can see that right here. Okay? Aldosterone, you can highlight that. All right? Down here you can see antidiuretic hormone. Remember I talked about that with diuretic braking? That causes the kidneys to hold on to water or reabsorb water here. Okay? Everybody got that written down now? Is that break time? No, we're good. All right, good. No, we're not yet, right?
Yeah. Is that when we have a CGM?
Oh, this is right. It's the CGM, right? Okay, we have that every year. Yeah. Yeah, it makes a difference. My son's a type 1 diabetic, and he wears a CGM all the time. But it rings differently than that. It's a little bit different. He's on a Dexcom, so yeah. But okay, so everybody's wearing them today?
Yeah.
Great. Okay, this is exciting, right? You can see how your body regulates all that blood sugar. Okay, good. All right, I'll have to thank Dr. Foles for that. Is that Dr. Foles doing that? Yeah. All right. She couldn't do it during the endocrine module, right? Well, we're actually talking about diabetes. We're doing it during hypertension. All right. And anyway. So I'm super used to that. Don't worry about it. So what I want to tell you now, I want to give you three terms. 3 terms. And it's not on here, so I need you to write it or type it down. Okay? Because I want everybody to understand what I mean when I say the following. Okay? First word that we're going to talk about is reabsorption. You all have heard the word reabsorption when we're talking about kidney function. kidneys reabsorb sodium. They reabsorb water, right? What does that mean? It takes it back. So reabsorption is the movement, okay? That's,
It sounds like a
we have ghosts back there or something like that?
Oh, it's not like somebody.
Let me check it.
Is everybody okay? Everybody check? Everybody's good?
Let me good.
Look, if it's outside, we don't have to worry about it, right? We good, Kingsley? All clear? If it's in here, we got a problem. All right, we're good. All right, back to reabsorption, okay? Reabsorption, it's a miracle I actually made it through grad school. I got the attention span of a gnat, right? Okay, so reabsorption is the movement of water, H2O, and electrolytes. The movement of water and electrolytes, right? From the renal tubule into the blood. Okay? I'll say that again. You guys ready? It's the movement of water and electrolytes from the renal tubule to the blood. Everybody got that? We're good? All right. Secretion is exactly the opposite. Okay? Exactly the opposite. Movement of water and electrolytes from the blood into the renal tubule. So it's all you have to write down is it's just the opposite. Okay? So movement of water and electrolytes from the blood to the renal tubule. Because I'm going to use these terms and I don't want you to be confused. Okay? And excretion is the last one. Excretion is elimination of water and electrolytes from the body. Excretion, okay, is the removal of water and electrolytes from the body. Okay? You guys got it? Okay? If I say that, one of those words, and you're like, oh, I don't remember, raise your hand. All right? I will clarify that for you. Okay? Because I know it can be a little confusing. It took me a long time to get those straightened out. Okay? All right, we're good? All right. So again, why is this picture important? Because it shows you the different parts of the nephron and where your diuretics work. Because where they work matters with regards to their efficacy, how powerful they are. Okay? All right. Moving on. We got our thiazide diuretics. Okay? Kingsley, yeah, go ahead.
Aldosterone apparently from the diagram is working only at the descending loop of L. No aldosterone.
Yeah, aldosterone, yeah.
Yes, it's working at the descending loop of L.
It's aldosterone is working right here in the collecting duct.
Okay, collecting duct. What happens to sodium there?
Where? In the proximal convoluted tubule?
Yes. Does it not affect it at the proximal and at the distal?
It's reabsorbed extensively in the proximal convoluted tubule, but it's not regulated by aldosterone. It is, however, and you guys don't need to know this, but I'll tell Kingsley because he's asking. Angiotensin 2 increases sodium reabsorption right here in the proximal convoluted tubule. So that's the one hormone that I'm aware of that will regulate sodium reabsorption there. Okay? There's no hormonal regulation of sodium reabsorption in the loop of Henle that I'm aware of. And then when you go over here in the collecting duct, it's aldosterone. Okay? Great. Thiazide diuretics. These are our first one. And again, look, if you're like struggling right towards the end of the exam and you're like, okay, I got to triage some stuff. Do not triage thiazide diuretics. Okay, they're important. Okay, one of your first line agents. Okay, so this is your pharmacophoric structure here. Okay, it's based on a sulfonyl benzothiadiazine 1,1-dioxide. Okay, that is the pharmacophoric structure there. Do you need to know that? No, you don't. Okay, but there's the pharmacophore right there. All right. What is important, I think, with this, okay, and like we discussed the other day, is that because of the unique chemical pharmacophore of your thiazides, okay, you can make water-soluble sodium salts, okay, that can be used IV if needed. And the same thing goes with your loop diuretics like Lasix or furosemide, okay? All right? All right, so let's take a look at the the structure-activity relationships associated with this pharmacophoric structure, okay? Here's the pharmacophore here that I showed you on the previous slide. So I'll repeat it over and over again, okay? We'll go back just so you can see it here, but I've got the carbons numbered, okay? Some of them at least. The first thing is that when the thiazide diuretics were developed, okay, scientists synthesized a whole bunch of compounds that looked similar to this. That's how we used to do drug development. Okay? We still do it to some degree, but not as much. We use computer modeling a lot more. But some of the early derivatives of this drug, you don't need to know this, but had a double bond here between C3 and C4. Okay? And what scientists at the time, as they were developing this, realized that if we reduce that double bond between carbon 3 and carbon 4, okay, that really significantly increases potency. Okay, so that was kind of part of the drug discovery process. That's why hydrochlorothiazide doesn't have a double bond between position 3 and 4. Okay? They also realized, okay, that substitutions, especially alkyl substitutions, all right, at R3 would increase lipid solubility and also increase duration of action and potency. Okay? So alkyl substitutions at position 3 are important for improving the duration of action and for potency. Okay? If we see here, okay, we've got, these are some of your substituents for hydrochlorothiazide right there, okay? I will tell you, I don't get really too excited about this from an exam standpoint because there's, like dihydropyridine calcium channel blockers I really like. ACE inhibitors I really like. Again, don't get too bent out of shape with this if you don't get it, okay? The other type of thiazide diuretic that we have, besides hydrochlorothiazide, is a drug called chlorthalidone. Okay, how many people have dispensed chlorthalidone before, right? Pretty common. Chlorthalidone is referred to as a thiazide-like diuretic. Here it is right over here, okay? You see it? Now I want you to take a quick look at this. Take a quick look at chlorthalidone. Look at its chemical structure, okay? Does that look anything like this? Number one? Or number two? One? Two. I feel like I'm giving an eye exam right now. Right? It doesn't look anything like it, does it? Right? What happens with chlorthalidone is that when it's administered, okay, it undergoes a spontaneous chemical reaction, okay? And it forms this part of the molecule here, okay? So the hydroxyl group loses a proton, all right? You get a keto function here, and you can see now this looks more like this, okay? This does look more like this. You almost have, a six-membered ring here. It's close. So you have this and this part looks an awful lot like hydrochlorothiazide. And then you've got this aromatic ring over here. Look, all I want to tell you is you're like, I'm looking at chlorthalidone and it looks nothing like hydrochlorothiazide. How could they work the same way, right? How could they be kind of part of the same? Well, it's because in the administrative form of the drug right here, okay, it's got one chemical structure, it spontaneously converts to this particular structure here, which looks an awful, this part right over here, and I'm circling here, looks an awful lot like this molecule right here, okay? If you don't believe me, you can look at it later on. All right, now, let's talk about the pharmacology, which is, in my mind, way more important here for this, okay? A little warm in here. All right, so thiazide diuretics, and I want everybody to understand this, okay? I'm going to say this, so pay attention. Have their mechanism of action in terms of their blood pressure lowering effects changes over time. I'm going to say that again. A drug like hydrochlorothiazide or chlorothalidone, okay, their blood pressure lowering effects, their mechanism of action, changes over time due to diuretic braking. Okay? Everybody hear what I'm saying here? Okay? Now, during the first several weeks that patients are on hydrochlorothiazide or chlorothalidone, they're going to experience a lot of diuresis. They're going to have to urinate a lot, right? Because you're getting that diuretic effect. There are other things that loss of water certainly contributes to the blood pressure lowering effect, right? Because if we lose water, what happens to blood volume? It goes down, right? What happens to preload? It goes down, right? What happens to stroke volume? It goes down. What happens to cardiac output? It goes down. Very good. Okay, great. But guess what happens over the first couple of weeks, too? Diuretic braking. Okay? So here is the thing that is so fascinating about hydrochlorothiazide. We've had it forever. It's cheap. It's effective. First couple of weeks, patients may have problems. I gotta go to the bathroom all the time, blah, blah, blah. But after about 3-4 weeks, the diuretic effect disappears. And blood volume levels return to pre-drug levels, okay? Because the diuretic effect is gone. Yet, the blood pressure still stays low, even after you've lost the diuretic effect. Does that make sense to everybody? So the big question is, what's going on here? If this drug isn't causing diuresis anymore, loss of water, okay, or natriuresis, loss of sodium necessarily, okay, how can it possibly be keeping blood pressure low? Well, it has a second and even more important mechanism of action, which we're going to talk about. Okay? I'll get to that in a minute. I'm not going to spoil it for you. Okay? Let's talk first about that diuretic effect. Okay? Site of action of the thiazide diuretic is the distal convoluted tubule, that one of the left, the next to the last segment of the nephron. Okay? There's a protein transporter there that I showed you in that last slide that causes reabsorption of sodium and chloride. And where sodium goes, water follows, right? So you get sodium, chloride, and water reabsorption. Okay? How do these drugs work, at least initially? They bind to that sodium chloride symporter protein and inhibit it, and prevents sodium reabsorption in the distal convoluted tubule. And if we do that, water reabsorption is reduced, and we get sodium and water loss. That's the diuretic effect. Okay? So the bottom line is, by inhibiting that protein in the distal convoluted tubule, and I have a picture of it in a minute, that will stimulate sodium and water excretion, okay, from the body. That's the diuretic effect of the drug. Like I said before, it's a transient effect, meaning you only get that diuretic effect for 3 or 4 weeks, essentially, and then it starts to dissipate in most patients. Okay? Now, let's take a closer look here. All right? So, see this diuretic picture here? I think I probably pulled it out of the Martini book, or this, the Nephron. picture here? This is what a nephron actually looks like. A nephron doesn't look like this. That's when it's all kind of laid out flat on a piece of paper. It's, you know, and we do that in a lot of our anatomy and physiology books so that you can see everything clearly. There's the distal convoluted tubule there, right? There is that protein that thiazide diuretics inhibit, okay? But if you were actually looking at a nephron under a microscope, it looks more like this. And this is the distal convoluted tubule over here. Loop of Henle, ascending limb of the loop of Henle. Here's the distal convoluted tubule right through here, and here's the collecting ducts. Thiazide diuretics inhibit a protein here in the distal convoluted tubule that prevents sodium and chloride reabsorption. But this diagram, we can't see that, can we? Because it's more of a big picture, right? So let's move over here to this picture on the right, okay? On the top here is pictured a single epithelial cell in the distal convoluted tubule. So we're looking at a microscope, we're looking under a microscope, we're looking at one single cell in this part of the nephron. And we're seeing all of these proteins here, okay? And what happens is, okay, your thiazide diuretics work right here. The protein that they block is called the NCC protein, okay? That's the one that reabsorbs sodium and chloride from the lumen of the distal convoluted tube, okay?
From the binding of the thiazide to BCT, is this reversible?
Pardon me, Kingsley?
The thiazide binding of BCT, is this something that is reversible?
Yeah, it's a reversible binding. Yeah, it's a reversible type of binding. Yes, absolutely. Okay. Now you can see up here, there's a lot of other protein transporters here. Okay. All right. And when we inhibit this one protein here, guess what that's going to do to the rest of these? It's going to change their activity, right? And one of the things that will also happen is that calcium here will be reabsorbed into the bloodstream even more heavily than it normally is here, this TRPV5 channel, okay? So when you inhibit this protein here with a thiazide diuretic, what that does is it actually promotes calcium reabsorption, okay, into the blood, all right? Now, let's pretend that we block this protein right here, the NCC protein. We've got sodium building up in the lumen here, right outside of the cell. Where is it going to go to? It's from the distal convoluted tubule. It's going to flow through the distal convoluted tubule, right? And enter into what? The collecting ducts right here. And something very special happens in the collecting ducts when this drug is being used. Okay? And to understand that, we're going to go down here. Okay? We're going to go down here. Okay? And my arrows kind of floated and moved around there, I'm sorry. But the job of the collecting ducts, okay, is to capture any leftover sodium that's coming their way after all that fluid has gone through the nephron, okay? That's what the collecting duct cells do. Their job is to capture whatever sodium left over that they can, okay, before it exits into the ureters and into the urinary bladder, okay? And sodium reabsorption here is regulated by what hormone? Aldosterone, right? When aldosterone levels are high, sodium reabsorption will increase. When they're low, it will decrease. At any rate, the sodium comes down through here, okay? Your collecting ducts, cells, are going to try to capture as much of it as it can, okay? But there's a cost to that. Okay? For every sodium ion that is captured here in the collecting duct, you lose 1 potassium. So the more sodium that these cells collect and reabsorb into the bloodstream, the more potassium that's lost. Okay? Why does this matter? Because one of the things that hydrochlorothiazide and chlorthalidone do is cause potassium loss from the body. Or another way of saying that, hypokalemia. Yep, hypokalemia. Okay, how does that happen? It's because of what's going on here in the collecting duct. Sodium reabsorption is being blocked up here in the distal convoluted tubule. That sodium then flows down into the collecting ducts, where those cells there attempt to reabsorb as much of it as it can. But every time a sodium ion is reabsorbed there, guess what gets secreted? A potassium ion. So the more sodium that's reabsorbed, the more potassium that's lost. There's a trade-off. Your body's holding on to sodium, but guess what it's doing? It's losing potassium. Okay? And that can be a problem. Okay? Go ahead, sir. Give me one. We're going to do one or two more minutes, and we'll take a break. Go ahead.
So the intention of the drug is to lose sodium.
The intention of the drug is to lose sodium, right, and water. One of the side effects, unfortunately, is that it inadvertently causes potassium loss, because that kidney is going to try to hold on to as much of that sodium and fight the drug.
So my question: where does the sodium go when it keeps going?
And sodium keeps going up. So some of that sodium will be reabsorbed and goes back into the blood, but it's a very weak mechanism.
So that's why it doesn't.
Exactly. So again, let's say, let me give you just some hypothetical numbers. Let's say we use hydrochlorothiazide up here, and 100 sodium ions are prevented from being reabsorbed right here. And all 100 of those sodium ions go down into the collecting ducts. Maybe 10 of them are reabsorbed there. But you're losing 10 potassium ions that you normally wouldn't. Does that make sense?
Yes.
It's a very weak mechanism, but yet,
Surprise.
right. When you use a loop diuretic, I'll go there really quick, right? Loop diuretics work in the loop of Henle. When you block that mechanism, that sodium reabsorption mechanism in the loop, now let's say that number 100 goes up to 1,000. Now you've got 1,000 sodium ions coming into the collecting duct, and 100 of them are reabsorbed. Now how many potassium ions are you losing? 100 instead of 10. So your potential for hypokalemia with loop diuretics, higher than that of your thiazide diuretics because of how much sodium they're blocking. Okay? And we'll go over that again when we talk about loop diuretics and heart failure. Yeah?
Yeah, just from what you were saying, I'm thinking about the site where the reaction is happening. Does it also affect the efficacy of each one? It says like, oh, sodium is not maybe so. It's going back. It's going into the duct at one side, and it's going to be reabsorbed back at another side. Like,
So if sodium gets reabsorbed right here, right, it's going right into the bloodstream. Okay? It typically won't be secreted back into the nephron, if that's what you're saying. It'll stay in the blood. Okay? So once it gets reabsorbed, typically there's a lot of, in the nephron, when you look at its anatomy and physiology, there's a lot of spots in the nephron where sodium can be reabsorbed into the bloodstream. But I'm trying to think, and I can't remember, that doesn't mean that there isn't, but a part of the nephron where sodium actually gets secreted from the blood back into the tube. Does that make sense? Once it gets captured, it's held on to. Okay? All right, these are great questions. Now, effects on electrolytes. You guys hang in there for 2 more minutes? Okay, because this is really important. Okay? Oh, go ahead.
When you go back in this slide,
Yep.
is this process a peculiar to
It's particular, you mean the potassium loss? It's specific for thiazides and for loops. They're notorious for that. Okay? All right, you guys got that? Let me ask you guys a quick question, real quick. What if we had a drug that blocked this ENaC channel right here. What do you think would happen with potassium loss then? Because remember, so this is where sodium's reabsorbed, right, in the collecting duct, and then as a result, potassium gets secreted. If we block this sodium channel here, guess what we can do? We can spare potassium, or hold on to it, right? That's your potassium-sparing diuretic, so you know what I ran. Okay? That's why sometimes you'll see hydrochlorothiazide compounded with, or combined with trianthrene or miluride. Okay? Because they can build a second diuretic in there that will prevent that potassium loss. It's not always necessary, but you have if you need it. Yeah, absolutely. I was just asking, and I'll go over this again when I talk about that drug. We know, right, when you give a patient like me hydrochlorothiazide, right, I'm going to lose potassium more than I did before, okay? And that potassium loss occurs right here in the collecting duct. And the mechanism by which that happens is that sodium that's not reabsorbed up here, because this is where the thiazide diuretics work, find its way into the collecting duct. The ENaC channel, the sodium channel, okay, pulls sodium out of there into the collecting duct cell and into the blood. But at the same time, what's it losing? Potassium, right? But if we could block this mechanism down here, we could prevent loss of potassium and probably even increase a little bit the sodium loss that we get with our thiazide diuretics. Does that make sense? Okay? Yeah, absolutely. That's important. We'll go over that again. Real quick here, effects on electrolytes. You gotta know this. Okay? Now, when I talk about effects on electrolytes, this is another thing. I'm talking about it like a pharmacologist would, not like a clinician. So you gotta be able to translate. I'm gonna help you with that. Okay? First of all, thiazide diuretics increase the excretion, this is where our three terms come in, of sodium and chloride. Elimination of sodium and chloride from the body, right? If you're a clinician and you're talking about a patient where this is happening and their sodium levels get too low in the plasma, what clinical term do you use? Hypo what? Natremia, right? So again, thiazide diuretics promote sodium loss from the body and chloride loss. And if it gets to be too bad, that can lead to hyponatremia. Okay? That's more common in loop diuretics that are more powerful, okay? But it can still happen in certain patients with thiazide diuretics, at least based on what I've heard over the years from clinicians. Okay, everybody got that? Okay? Increased potassium and acid secretion. That's important too. So thiazide diuretics promote the loss of potassium ions, we know that, right? And hydrogen ions from the body. So that can cause what with regards to potassium? Hypokalemia, right? And what could it do to pH? It could potentially increase pH, right?
Yeah.
Make it more basic, okay? It can decrease excretion of calcium. Remember I told you that, right? It causes the body to hold on to calcium, okay? So your plasma calcium levels can go up. Now, I'm not saying it would happen, but again, when calcium levels get too high, what's that called? Hypercalcemia. Right, very good. I'm not saying that that happens with this, but calcium levels can increase, okay? All right? Urate or uric acid. It also causes the body to hold on to that. Where could that be a problem? Gout. If you have a patient that has gout, right, this could precipitate a gouty attack. Right? If your body's holding on to more uric acid, which is what causes gout, right? Okay? Make sense? And it can cause an increase in magnesium excretion or a reduction in magnesium levels in the blood. Okay? So again, all these words up here describe what's happening physiologically. Excretion, okay? From the body, elimination from the body. You've got to take that knowledge and then translate that into what happens in the blood. Are blood levels going up of that electrolyte, or are they going down? And if they get outside of normal ranges, what do we call that? Hyper or hypo, blah, 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 whatever you're talking about, right? Okay? Everybody got that? Efficacy. Weak diuretic. Okay? This drug, as a diuretic, is relatively ineffective if your glomerular filtration rate is below 30 to 40 mils per minute. Okay? So again, in order for it to be effective as a diuretic, it's got to be, your GFR has got to be above that number. There are some exceptions, okay? Metolazone, indapamide, have you ever heard of these? These are other types of thiazide-like drugs. Okay, there are exceptions to that. All right? And Dr. Naeem will probably talk more about that. She may. All right. So we're done with the diuretic effects. Let's go take 6 or 7 minutes, okay? Get up and move around. This room is like, feeling a little tropical in here. I don't know about you, right? Yeah, humid, right? Okay, go take a break. When we come back, we'll talk about the vascular effects. Make sure you come back, okay? Got that? Yes, ma'am.
No, I don't have the lunch against
So that's supposed to be so awesome.
Yeah, so it's really rare to like it would be really
Yeah, like the enormous ones. Yeah.
It was
100 years old.
Yeah, I do too.
That's too cool. I'll keep that right by that.
Yeah.
Awesome.
So like, this is just like how the body works.
Do they bother? You know, do they?
Yeah, I remember.
I've seen documentaries when they right? That's where I've seen are running to the ocean because predators are ready to death.
Sí, la definición.
So like, yeah, so like, literally this would happen. But that's awesome.
Because it reminded me of what you told me. It's like, have fun. And I saw that turtle.
That's all, yeah. You know, and that's what life's all about. Sometimes we get so trapped in this area, right? We forget sometimes what life's about. Oh my goodness.
You like the water, Dr. Cohen? Okay.
O sea, pues we have like the transfer to potassium being.
Pero de la matita.
Pero yo no sé cómo bregar. Con eso es la primera vez que yo brego, no sé cómo bregar. No sé nada, es como si fuera
Es como de la iPad.
si el mismo una es más fácil que yo me dé el
La persona de cada conmigo. Vamos. Yo, eso vamos para iglesias. El domingo.
¿A cuál ustedes fueron? ¿En dónde?
Yo no llegué a YouTube.
Yep.
Sí, con la de José.
Got it.
Tómate la de niño.
¿Pero en qué área es?
Okay.
Pero es el tiempo.
¿En qué área es?
Eso era. ¿Quién vino?
Exactly. So that just verifies her number or, you know.
¿Quién vino?
So that's good. I'm,
Oh, yeah, this, like, stop.
oh, God.
¿Tú sabes qué quiero cambiar?
Awesome. All right, I can't wait to, I can't wait.
Galletas por sol.
Just text her and let her know I was in class, okay?
¿Cómo es verdad ella? No, mortadella, el mortadella es el jamón
Ernesto, explica la respuesta de ella.
Vamos.
Yo no sé. Que no tomen cuenta de ella, dice. Así que es el paso porque se llama.
Y esto nos tiene que dar una clase de canción.
No, en verdad ya yo estudié los primeros tres lectures con Cherry y el único lecture que no terminé
Me explicó
No.
2-minute warning. You got 2-minute warning.
I don't know what's going on up there, but there's a set up Reddit's up there. It's like, what?
Es que yo no soy de. Yo soy de leer y escuchar. Sí, como que visual.
A limited traffic. I mean, sure you.
Y yo escuchando para
1 minute. 1 minute.
Eso yo no lo ingeniería y me
Everybody's CGM's gonna be going off. Soda and snacks and stuff like that, right? Let's hope not. All right. Let's have a seat. Let's get started again. Okay. All right. Welcome back. Thanks for coming back. Boost my confidence. I think we're missing some folks. All right. So we spent a lot of time talking about the molecular, cellular, tissue effects of the thiazide diuretics, right? Hydrochlorothiazide, chlorthalidone, okay, and other drugs in this particular category. We know that when we administer these drugs, they actually have a diuretic effect for the first several weeks that patients are on them. And that it contributes significantly to the blood pressure lowering effect, or at least a little bit to the blood pressure lowering effect. But as scientists developed these drugs and studied people that were taking them, again, they were extremely puzzled by the fact that after about 4 weeks of therapy, the diuretic effect of these drugs started to diminish or disappear. The patient's blood volume levels started to come back up to where they were pre-therapy, but yet blood pressure still, the blood pressure lowering effect was still there. And so they started looking, what else could be going on here? We know that the diuretic effect starts to fade 3 to 4 weeks into therapy due to diuretic breaking. But the reason why thiazide diuretics in the long run lower blood pressure is because they have vascular effects, okay? They reduce SVR or afterload. Frankly, and I haven't checked on this in a couple of years. I'll admit that, even on recording here. But even as of several years ago, we still don't understand how they do that. We know that they do. We've been able to observe that, but we don't know what that cellular molecular effect is, what it is. So again, we talk about the effects of, if I were to ask you a question on the exam, okay? Describe the blood pressure lowering effects of a patient that's been on hydrochlorothiazide for 6 months. A, reduction in blood volume. B, reduction in cardiac output. C, reduction in preload. D, reduction in SVR. What are you going to pick? D, SVR, right? Okay? All right. So again, it's important to understand that the mechanism of action responsible for the blood pressure lowering effects does change over time with this. We don't understand why or how, but we do know that it happens. Okay? And it happens again anywhere from 1 to 2 months into therapy. It varies from patient to patient. The diuretic effect kind of goes away, and these drugs are really great. They reduce blood pressure well. They've got great morbidity, mortality data, right? Dr. Naeem's going to talk to their first-line agents, right? They're cheap. They're widely available, right? Besides the potassium effects, they can cause dehydration maybe in older patients, but I think they're pretty well tolerated. Don't listen to me on that. Listen to her, okay? But, all right, they got a lot going for them. So again, summary of the thiazide diuretics. Yes, Kingsley.
When the body compensates for it, does the diuresis still continue?
So when as the body compensates through diuretic braking, okay, by activating the sympathetic nervous system, activating the RAS system, and releasing ADH, that will decrease the diuretic effect.
So diuresis will happen, but the blood volume will remain?
No, the blood volume comes up to pre-treatment levels. That's what was so shocking about it. And yet blood pressure was still low, right? It still remains low for 6 months, a year, 3 years, 10 years, 15 years, right? And so at that point, scientists were like, okay, so what's going on here? And they discovered that there's a significant vascular effect. So up here, right, okay, right over here, circle this and star it, okay? For chronic therapy, this is the blood pressure lowering effect, okay? During the first month or two, all of this is happening, okay? All of it's happening. And then this stuff over here disappears. All right, the reduction in intravascular volume, the reduction in preload, the reduction in stroke volume, and cardiac output, all of that reverses as diuretic braking comes into play, and all you're left with is a reduction in TPR or systemic vascular resistance. Okay? Yes? Katie.
I was like told about this question. How do you know which medication or patient you're going to use?
Yeah, that's a great question, right? Because you've got like 3 really great groups of drugs,
Yes.
right? Hydrochlorothiazides, right? You've got ACE inhibitors and ARBs and calcium channel blockers. I'm going to let Dr. Naeem answer that question because you're right. It is the question, isn't it? Right? And, again, if you're dealing with a patient that doesn't have any other health conditions or problems, might have high blood pressure, you may just be able to pick one, right? Okay? But there might be other things that are going on with the patient that you have to pick up on that might make you choose one over the other. And that's the trick with this, folks. You got to listen to Dr. Naeem when she's talking to you. It's like a detective story with this. You got to, when you get your patient, okay, you got to, hey, first they have high blood pressure, right? So what are we going to start them on? You got to look at everything now. What are their disease states? Okay, there are certain patient populations that respond to some of these drugs better than others. Okay, and so if you're dealing with that type of patient, you may want to start that drug over them. Okay, if you've got somebody with hypertension and kidney disease, right, you may want to start with ACEs and ARBs, right? Okay, so again, there's a lot to consider there.
And I think also the pharmacogenomics could also be a role to play.
Yeah, pharmacogenomics, I will tell you, Kingsley, it's a good point. With a lot of disease states it is, as far as I know, however, in an uncomplicated type of hypertension patient, we don't worry about pharmacogenomics. They don't do any kind of tests or anything like this. Because typically what's happening is, let's say I go in for high blood pressure, I go to my primary care doctor, okay? They're gonna take my blood pressure. They're gonna look at me and look at my chart. Okay, Colleen, go downstairs and get your ACE inhibitor, right? They aren't looking for that. Now, again, there might be special circumstances, right, where maybe you've got somebody who's got blood pressure that's incredibly difficult to control. Yeah, I have an aunt like that. She's on like 5 different medications, and it's barely enough to keep her blood pressure under control. There might be something going on, but again, It's not the norm. Typically, it's just, hey, use your parameters, pick a drug, start there. You know, bump the dose up as high as you can, see the people, and then add another one on, right? That's pretty much, that's the gist that I get from listening all these years. I don't treat patients with hypertension. I don't have PharmD. I'm not a clinician. I don't play one on television. Okay, so don't listen to me. Okay, listen to Dr. Naeem, all right? All right. Potassium-sparing diuretics. Again, we have more medicinal chemistry that I'm not terribly excited about, but I'm gonna do it just because it's my job. Okay, right? All right. Amiloride and trientry. Now there are a couple of different types of diuretics in this category. Okay. The name of this category, potassium-sparing diuretic, means that these diuretics help the body to hold on to potassium. They spare it. They prevent it from being lost. Okay? The vast majority of these that we're going to talk about, like trientherine and amiloride, these two, they're very, very weak diuretics. As far as I know, they're never used by themselves because they just don't have a strong diuretic effect. But like I said, they're often formulated with other diuretics like hydrochlorothiazide or loop diuretics to prevent potassium loss. And Dr. Naeem is going to talk more about that. Okay? All right? So again, you know what we're going to do here? Just FYI, all right? All right. I can talk to you about optimal diuretic activity. I mean, this is information that we gleaned when we first developed these drugs. You know, kind of, okay, if I stick functional group over here, will that optimize activity? Or if I remove this structure over here, will that eliminate activity? How can I make this drug molecule as powerful and potent as possible? You know, and again, you've got these two particular, drugs here, and only, this description here is only for amiloride, okay? You can see here that we noted, and I'll just go through this real quick. Carbon 6, you've got a chlorine substitution there that optimizes activity, okay? We've got the amino groups, all right, in positions 3 and 5, right here and right here are unsubstituted, meaning that they're just out there, okay? And the guanidine nitrogens over here are not multiply substituted with alkyl groups. They're just all, they're all hanging out there by themselves. There's no alkyl groups attached. That's what we know about amiloride. Again, no big deal. The probability of me actually asking a question. Cell phone?
No, 7.
Okay, got it? All right. All right, so where do they work? Where do these drugs work? In the collecting duct. I just showed you this before, right? Okay? What they do is they block sodium reabsorption in the collecting duct. And if we do that, we will prevent loss of potassium. So when you formulate these drugs with a thiazide diuretic or loop diuretic, what these drugs do is they essentially, block the ENaC channels here and prevent sodium from being reabsorbed in the collecting duct. And more importantly, potassium from being lost. Okay? So again, and I'm doing a total hypothetical here. I'm not a clinician, right? But if you have a patient taking hydrochlorothiazide, right, and their potassium levels start to drop, okay, there's different ways you can handle that, right? And maybe there's a combination drug, hydrochlorothiazide and amiloride, or hydrochlorothiazide trientherine you can give them, and that might bring their potassium back, or they can eat more potassium, right? Okay, that sort of thing. Dr. Naeem is going to talk all about that, but I want you to just kind of have your eyeballs on that when she does, okay? So these drugs, A, are not used by themselves as therapeutic agents. B, they help the body hold on to potassium and are often used in combination products, okay, with other diuretics that actually do cause potassium loss. All right, if you know those three things, you're good to go. And they work in the collecting duct, all right? You need to know these things from me, okay? Everybody got that? Big Mel.
Yeah, so,
Yep.
the previous PowerPoint, diuretics, it said that it would increase in sodium and chloride excretion.
Yeah.
But that only works for the loop diuretics, right? Because it does not work for the thiazide.
So both thiazide diuretics and, as we'll talk about, loop diuretics promote sodium loss in the body. They both do it, but they do it differently. Exactly. So right here, sodium chloride is excreted with thiazide diuretic. All right. Any sodium that's reabsorbed, okay, at any time is not typically secreted back into the kidney tubule. Okay. But with these drugs, with thiazide diuretics, okay, they promote sodium loss.
How is it reabsorbed?
That's right.
How is it sodium reabsorbed? Sodium.
Yeah, so right up here, the thiazides block sodium reabsorption here in the distal convoluted tubule, right? As the sodium exits the nephron through the collecting ducts, some of it is reabsorbed here, but a very small fraction of it.
That's when you take the thiazide.
No, you're taking the thiazide drugs that cause that to happen. Let's talk afterwards.
Wait, I think I figured out how to explain it a little bit better.
Really? Okay, Jess, you want the PowerPoint?
No, just.
You got the laser pointer. I'm giving it to you. Go for it, girl. There you go. Come on, go for it.
So.
Here, come on. Here's the laser pointer. You'll have to just pull the trigger right there. You got it. Be a teacher.
I don't even know how to work.
It's that trigger thing underneath. There you go. There you go. All right.
Boom.
Boom.
Thiazide diuretic. It's gonna block reabsorption, but we have to remember that reabsorption is into the blood.
Yep.
So therefore, it's still gonna be in this fluid and go down to the collecting duct, and that's why we get the hypocalcemia, because it's gonna go into the fluid and not the blood.
Mm.
Does that make sense? Like the blue is the fluid. It's not the blood.
That's it. That's the inside of the cell.
Okay, well that's how I'm gonna say it.
That's it. That's good. All right. Good job, Jess. Give me a round of applause. Let's get a round of applause. Look, yes.
So the sodium comes down to the collecting duct.
Yeah. Everybody, hold on a second so I can hear the question. Go ahead. But sodium comes down to the collecting duct.
And the body does with directly. The body naturally wants to hold sodium.
Yeah.
Okay, so in the collecting duct, when the sodium, some sodium goes into the blood, potassium goes out.
Yeah.
So potassium starting directly, it blocks the sodium from going into the blood.
Exactly.
Hence, potassium does not go out.
Exactly. That's exactly what we're talking about here. Okay. So again, like I said before, all right, what you need to remember here, all right, if you're confused right now, please just remember this. Okay, thiazide diuretics cause sodium to leave the body. Don't worry about excretion or reabsorption or whatever. Okay, they cause you to lose sodium. Okay, they also cause you to lose potassium. Okay, and that's important too. Okay. The mechanism up here can be a little bit confusing, but if you at least understand that it causes electrolyte changes here, that can lead to low sodium, low potassium, higher calcium and uric acid levels in the blood, and an increase in magnesium loss, which causes a lowering of magnesium. That's a good place to start.
So is it fair to say that they help in excreting sodium and reabsorbing sodium?
I say that one more time.
So you said diuretics would help in excreting sodium.
They help increase the excretion of sodium, right?
At some point it gets reabsorbed.
Yeah, a little bit, just a tiny bit.
So they promote.
So yeah, the drug promotes primarily sodium loss. The kidney will try to fight that a little bit, but the collecting ducts are terrible at reabsorbing sodium. They only reabsorb a small fraction. They're like the cleanup groups that doesn't do a really good job. And in fact, when they do their job, what happens is you actually lose potassium. Okay? Yeah, we'll talk about that. Yeah, we'll talk about that. All right, now back to this. Good questions. I want to make sure I can cover some of this stuff. All right. All right. Everybody got this with amiloride tramiptorine. They're sodium channel blockers. They work in the collecting duct, and they prevent potassium loss that can be caused by thiazide and loop diuretics. Okay, that's all you need to know. All right. Now, we're going to talk about our last class of potassium-sparing diuretics, okay? And these are our aldosterone antagonists. Okay? You guys have heard of these drugs before because I mentioned them earlier. Everybody seemed to recognize them, right? Spironolactone and eplerenone. Okay? These are all mineralocorticoid analogs, meaning they look like the mineralocorticoid hormone aldosterone, right? And we know that, right? When we talk about drugs, a lot of times the drug molecules that we're studying here look a little bit like their naturally occurring hormonal counterparts, right? That's how they fool the receptors into binding to them, right? Okay? Now, what you can see here, all I want you to see here is here's aldosterone here, okay? This is the structure of aldosterone here. This is spironolactone. They look similar, but there's some little differences, right? We'll go over here, and eplerenone is even a little bit different, okay? But they both look like spironolactone, or I'm sorry, they both look like aldosterone. Thank you. All right? Now, the big difference, and I want you to star this because this is super important. Spironolactone is an older aldosterone antagonist, okay? It works well. But the problem is it's got a ton of unwanted side effects, okay? Because it's not very selective. It'll bind to a lot of steroid hormone receptors, okay?
That was my question. That like since Lhasa is like a that the steroid backbone, like the cholesterol backbone, it looks like
it looks like testosterone, it looks like estrogen, it looks like a lot of different steroid hormones.
And that's why it can be used for some of the hormone-related things.
Exactly. Let's take a look at this. Okay, eplerenone, just before I get to it, eplerenone is a much newer aldosterone antagonist. It's more expensive, but the reason it's a little bit better is because it's much more selective for the aldosterone receptor. It doesn't have effects at these other hormone-based receptors, okay? So if we look at not the side effects, but just the receptors, okay, that the drug will block. Look at eplerenone. It's selective. It's a very selective drug for just aldosterone receptors, or we call them mineralocorticoid receptors, okay? Everybody see that? But look at spironolactone. It'll interact with mineralocorticoid receptors, which is good because that's the receptor we want to block, right? But it also interacts with androgen receptors, glucocorticoid receptors, progesterone receptors, and estrogen receptors. Now, I used to teach this, but I removed that detail because I didn't think it really mattered for you guys. But just so you know, spironolactone can activate some of these receptors or inhibit some of them. And this is what gives us the unusual sexual side effects that we see with spironolactone. Yes, sir?
So one of the side effects is
gynecomastia, right? Okay, yeah, absolutely. Gynecomastia. It's, in men, it's enlargement of the breast tissue. Okay? So that can occur in men. Sexual dysfunction, reduction in libido.
Last week I dispensed one of those.
Yeah.
And I asked the pharmacist, and she said that the patient was taking for like he's a
transgender care. Yes. Okay. Now again, and actually we're going to learn about that. We have a whole new block, I think, in the endocrine module. There's a whole new lecture or two on that. We're going to learn about that. But that's a good point. And I didn't know that. So it could be used, in terms of for transgender care. Okay, if you have a man that's transitioning to a female, again, spironolactone can cause the growth of breast tissue. Okay? All right? I didn't know that. That's good. All right? And you'll learn all about that in the endocrine module. Okay? So again, they both, from a blood pressure lowering effect or use in heart failure, are very equivalent in terms of their effectiveness. The problem is, one's got a lot more side effects, than the other one does. Okay? Everybody got that? So if I ask you on an exam, what's the difference between a eplerenone and spironolactone? Okay? Again, you should know that, hey, spironolactone blocks a lot more hormone receptors than eplerenone does. So there's a difference in the selectivity, receptor selectivity, and that translates into the fact that spironolactone has sexual side effects that Dr. Manani will talk about, okay, that you don't see with eplerenone. Okay? Everybody got it? Good. So where do these drugs work? They work in the same segment of the nephron that the other potassium-sparing diuretics work, like amiloride, triamterene, and that is in the collecting duct, okay? The cortical collecting duct, okay, in the renal cortex. Think about what aldosterone does. Let's go here, okay? Let's go back here real quick. I just want to show you this. And this does a nice job. This picture here, I don't know why I removed it, okay? But if we go back a couple of slides to our other potassium-sparing diuretics, look at what the picture shows you here. There's aldosterone, and there's spironolactone, okay? Here's your mineralocorticoid receptor, right here. What normally happens when aldosterone is released from the adrenal glands, part of the RAS cascade, aldosterone will activate your mineralocorticoid receptors, okay? They will translocate to the nucleus of the cell and stimulate transcription and translation of very specific proteins that are responsible for sodium reabsorption. ENaC channels here, and the sodium-potassium ATPase on the blood side of the cell. Okay, so as those proteins are produced in higher and higher quantities, the collecting duct cells can reabsorb more and more sodium, right? And more water. So you can hold on to sodium and water, because that's what aldosterone does. But what else does it do? It stimulates the loss of what? Potassium, right? That's what aldosterone does normally as a hormone in our body. Now, spironolactone, what it does, or eplerenone, because it looks just like aldosterone, can bind to the mineralocorticoid receptor and block it, preventing the production of these proteins up here and reducing the ability of the collecting duct cells to be able to reabsorb sodium and water. And that, in turn, eliminates potassium or reduces potassium loss there, because these indeed are potassium-sparing diuretics.
So it's a direct antagonism of aldosterone.
Antagonism of aldosterone. That's exactly how they work. They antagonize aldosterone. That's where they get their names, right? These are your These are your aldosterone antagonists. They block aldosterone. So guys, if you know what aldosterone does as a hormone, it's super easy to know how these drugs work because they just block that and reverse it. Okay? If you know this aldosterone, when it's released, stimulates the kidneys to hold on to sodium and water but lose potassium, and you have a drug that blocks that, now all of a sudden you're going to be losing sodium and water, but your body will hold on to potassium. Okay? You only need to know one thing. And then just realize, hey, if I have a drug that blocks that, the opposite happens, right? It's just a basic pharmacological principle that you can use if you are confused or you can't remember something. All right, Kenny.
We also have direct breaking here.
Not necessarily. Not with the potassium-sparing diuretics. We don't typically see diuretic breaking because they're not as powerful of a diuretic as the thiazides or especially the loop diuretics. Diuretic breaking really only happens when you're dealing with, powerful diuretics or the patient's particularly sensitive to that diuretic. Okay, with the amiloride, triamterene, and then eplerenone and spironolactone, you don't typically see diuretic breaking because they're not that powerful of diuretic agents. Okay, these aren't first-line agents for hypertension. Okay, they're second-line agents, but we do use them a lot in heart failure. We'll talk about that in a couple of weeks. Okay.
So this one was not going to
So they can. So yeah, again, when we take a look at, here we go. Yeah, we'll get to that in a second, okay? All right, guys, so again, right here, this is the summary of our aldosterone antagonists, right? They do have some diuretic effect. They reduce intravascular volume. They reduce preload, stroke volume, cardiac output, and the arterial pressure, just like a traditional diuretic would do. This summary slide here is super important. Okay? All right? Because this summarizes all of the major electrolyte changes that occur with the 3 groups of diuretics that we just talked about. Okay? And that's important to know. Okay? I will probably ask you a question. I'm sure I'm going to ask you some questions on that. I know Dr. Naeem is going to ask you questions on that. Okay? So you need to understand what's going on physiologically here. Okay? Right? And you need to, and remember, I want you guys to highlight this real quick. Highlight the plasma electrolytes, because this is what this is talking about. So in thiazide diuretics, there's a reduction in sodium and chloride in the plasma or blood. That's what this slide is showing you. This is kind of the clinical translation, right? Here, they also cause a reduction in potassium in the plasma or blood, okay? So again, if you're thinking like a clinician, this is the slide you need to know. Because Dr. Naeem can go over this as well, too, okay? I explain it as, hey, we're losing sodium from the body. There's an increase in sodium excretion. And that causes a reduction in the blood levels of sodium, right? Which can give us hyponatremia, right? So it's just kind of a full explanation of what's going on there, all right? We're good? A couple of things, real quick, housekeeping items, I told you. I'm going to be out of the office all day tomorrow. I won't be here. I'll be back on Friday, okay? And, I want you to start digesting this, really working on it. I think you have a class tomorrow and then you have Friday off. Is that right? No, or you guys have class on Friday too? Okay, this week. I know there's a couple of Fridays you don't have class. I think you have it scheduled. I should be right on. So again, stay up with the material. Okay, you guys know me. I move at a snail's pace compared to some other folks, right? Dr. Naeem's going to come in and she's going to move, all right? So stay up with the material. Let me know if you have any questions. I'll let you know when the review session is going to be for this. Good luck, okay? I'll see you guys in a bit, okay? Alrighty.